અરે એમ નહીં, તમારું જે જૂનો હશે જો મેસેજમાં મેં લખ્યું છે, તમારે એકવાર જઈને અહીંયાથી કન્ફર્મ કરવાનું અને જે ઓટીપી
Patel Dental College, Saket Patel University, for this extraordinary webinar series, which is nicely termed as BOSS, Basic Oral Surgical Skills. They say that going back to the basics strengthens your foundation, and with good basics, you will have endless options. With this quote, I take this opportunity to invite our beloved Dean Sir, Dr. J.R. Patel Sir, to say a few words.
Good afternoon to one and all, and respected mentor of today's program, BOSS series of webinar, which is organized under the leadership of Dr.Anil Managutti, Department HOD and Professor, Department of Oral and Maxillofacial Surgery. Our today's mentor, Dr. Ramkrishna Shenoi. Welcome, sir, on behalf of the whole team. And it's a good thought by this Department of Oral Surgery to start with this kind of series, as Dr. Rushid was telling, that if we want to have a advancement in any skill, then the basic you should be master in basic. You have to learn basic first, and then you can have some advanced technology or learning towards that. So I think it's a good effort by the Department of Oral Surgery. So once again, I congratulate on behalf of university as well as Managutti Patel Dental College. And I hope all participants will definitely enjoy, because they have a right selection of mentors, known people they have selected. And I know Dr. Ramkrishna, as my connection is with VSPM. I visited VSPM, and how academic and even clinical mastery is there in that college also. I have observed it during PG convention. I have visited all department also. So I'm sure that our all participants, our all delegates will definitely learn, will have definite some take home points out of Dr. Ramkrishna's deliberation today. So all the best to the department as well as all delegates for happy learning, happy e-webinaring, and you will have definite advantage of this series. So I would like to request all delegates that for all session, whatever Oral Surgery Department have planned, you try to attend. You attend all sessions, all means in the whole series of webinars, whatever they have declared. Dates also they have, I think you have declared the dates, right? Future dates also. Yes, so accordingly you mark the dates and you attend. And today is a good beginning. Opening batsman is with us, Dr. Ramkrishna. So please enjoy it. Once again, wish you happy webinaring. Thank you.
Thank you so much,
Thank
sir,
you, sir. Thank
for
you.
words of enthusiasm. Before moving further, I request all the delegates to please keep your audio off, keep it mute, unless otherwise required. In case if you have any query or any question, you can drop it in the chat box. We will take the question answer session from there after the lecture is over. Also, once every lecture gets over, we will be sharing a feedback form to the mail addresses that you have provided during the registrations, and you are requested to fill the feedback forms, because all those who are filling the feedback forms will be giving away the certificates at the end of the entire webinar series. Yeah. So moving further, I request Head of the Department, Dr. Anil Managutti, sir, to welcome the speaker for the day and take you further. Thank you.
Thank you, Rashid. So to introduce, because it's just an formality to introduce Ramkrishna Shenoi sir, because everyone in India knows India and internationally. So to introduce, Sir is the Vice Dean and Director of PG Studies, Professor and Head of Department of Oral and Maxillofacial Surgery, VSPM Dental College, Nagpur. Sir has done a BDS and MDS from Nagpur, and he has done other degrees, PGD, HHCM, and Master MBA also in Health Administration. Sir has presented national and international papers, and he has got more than 100 publications. He had a post of offices. He was a scientific convener of Indian Society of Oral Implantologists, and he was the organizing chairman of AOMSI Nagpur conference. Many are there, so I will not take much time to read all these things. But Sir had achieved a lot of awards, and I would like to mention few awards in that IADS Awards in April 2019 and UG and PG Academician of the Award. Sir had then Dental Leadership Award. There are n number of awards are there. So we are very grateful to have you, sir. And you are the best person to teach this basics in oral and oral surgery. This boss to start with. And sir, as I discussed earlier, he in the local anesthesia, this has to be taught very well. And he has designed some modules where when on the models, when the students put the needle on the inferior now the light blinks. So actually, sir has a half day or 1 day workshops. This I really happy to have you, sir. Thank you, and over to you, sir.
Thank you so much, Anil. Awards can be many, but rewards are very few. And one of the greatest rewards that I have is a friend like you. Believe me. So
thank you,
Anil, have been a lifesaver for me last year because I had nearly lost my laptop when I was on my way to Chidambaram, and Anil helped me out by sending the PDF which he had converted back into PPT and mailed it to me, which I presented at the Annamalai University. So thank you, Anil, for that. I can never forget with the short time that we had, that you could do it. And it's always a pleasure to be with you, usually physically, but this time in a virtual way. And I thank you for making me a speaker for this superb event. And I'm sure in the coming few days and events, you got the top class speakers. I'm just a mere speck in the ocean. There are big, big speakers who are going to come up. And I thank you for inviting me. Patel sir, this is the last, I think I visited the college in 2018 for the master class AMSI where I had, yes. Yeah. And it would have been a great fortune for us if, there was no corona pandemic and you could have come to Nagpur for the IPS conference of which you are the IPS president. So we missed you, sir. And hopefully, whenever this gets over, you'll plan a trip to Nagpur.
Sure, sir.
I really have fond memories of my masterclass, which was there in 2018. And Anil and his team, Rushit, Shailesh, and so many more, Nirav, they all helped me, very much. Thank you so much. And I'll start sharing my screen. Thank you for the wonderful introduction of mine. I don't know whether I deserve it.
Okay. Of course, sir, you deserve for it.
Thank you, sir. Thank
you. I
so
did only little bit, sir. Actually, it's
yeah. So we start off with this particular event, and again, I would like to thank the management of Sankalchand Patel University and Narsinbhai Patel Dental College, Visnagar, for having me. As we are battling with the corona pandemic, I think we should pay respects to all those corona frontline workers, be it doctors, paramedics, policemen, the sanitation workers. So we should pay a big tribute to them. My own postgraduate students have done COVID duties in the most parts where it was bursting like a volcano. So a big sense of gratitude to them, and that's how we do it. Now, when we talk about a physical event or a webinar, the basic idea is that there should be an interaction the basic scheme is that we should have an interaction of ideas. We should brainstorm, and then we should come to something, that is definitely going to help us, and indirectly it's going to benefit the patient. Now, many a times, students wonder, ye kyun pooch rahe hain? Why is boss asking how much of adrenaline should be there? What is the maximum content of local anesthesia? So these are all things which are going to ultimately help you in your practice. They're not, we have seen clinical situations that the patient has gone into a toxic, patient has had a toxic reaction, or the fact that, the patient develops anaphylaxis. So it is vital that we sit and exchange ideas. I'm sure at the end of this webinar, maybe I am going to go back with a lot of things that are going to be there. So I think the topic is essentially the same. What we are going to talk about is predictable local anesthesia. And this presentation comes to you from BSPM Dental College, Nagpur. Here's a disclaimer. I'm not going to endorse any brand, right? However, you might see me taking the name of Septodont, because there are a lot of molecules of Septodont which we are going to talk about, and which would be helpful. But in no way I'm going to endorse any one of them. I'm not a brand ambassador. I have acknowledged in whatever way I can. The literature for local anesthesia is humongous. Okay, you check up, you just type in local anesthesia, Articaine, Lignocaine, and you're going to get thousands and thousands of manuscripts regarding the same. So what we are going to do is we are going to concise it in such a way that you are going to go back much wiser, and you're going to put that to clinical use. It's not just all about like a theory lecture. Morning se maila mein utha ke maine baat karna chalu kiya. It's not going to be like that. It's just going to be a compendium where we are going to make use of whatever clinical knowledge we have for our betterment and the patient's betterment. So basically, a patient comes to a dentist usually in India is because of the pain, and we have to, the best way that we can have a good practice is to practice painless dentistry, right? We are not allowed to, kind of advertise our skills or whatever. But what we can do is that, when we relieve the pain of the patient, at that time, the patient is going to refer us more patients by, by sending more patients to us, that saying that he's a good doctor. There's no pain when I get any kind of treatment done. Not necessarily oral surgery. It could be anything, endodontia. It could be a good prosthetic rehabilitation of the patient where you need local anesthesia. So this is the aim of the lecture, right? Anesthesia is always important, and there are a few things which come to the patient's mind as well as the doctor's mind, right? We have to ensure that there is pain-free care. Okay, the patient should be satisfied. Okay, and then obviously that's going to get us more patients, right? Most of the patients are afraid of the needle and to be in pain, right? So what is important is that, and I mean, good anesthesia is important, and patient satisfaction should be dentist's #1 priority. Okay, never extract a tooth if the patient is in pain, right? But that doesn't mean that you should ask the patient ki kaisa lag raha, because the patient is definitely going to say, the patient does not discern between pain or pressure, right? So it is left to us to explain to the patient as to what's going to happen. Okay. So the brief history in very short is actually Kohler and Gartner reported local anesthesia in 1884. So it's been more than 136 years. Halsted injects cocaine into the mandibular nerve and brachial plexus, right? Einhorn, this was the landmark where it happened, where Einhorn isolated procaine, and later on Lofgren in 1943 developed the best ever at that time. Even it's the workhorse of local anesthesia, that is lidocaine or lignocaine, or it goes commonly by the brand name of xylocaine. Okay, so between this, there have been a lot of changes that has happened. When Einhorn discovered procaine, it was something, it was a epoch-making discovery, because that reduced the pain. Cocaine because of its addictive potential, could not be used many times. Even in India, we can get cocaine, right? For medical use, it's extremely difficult. Only some very few practitioners can lay hands to it, and that is given basically for cancer pain. So the local anesthesia is basically, it's a reversible loss of sensation in a circumscribed area of the body caused by depression of the excitation of nerve endings or inhibition of conduction. Now this has to be remembered in your, for the third year and final years who are there listening to this. This is something that you should remember, right? This is going to be asked in your viva, right? And this obviously has something to do with clinically, right? When you inject local anesthesia, you are only relieving pain in that particular area. It's not like general anesthesia where the patient is rendered unconscious. Okay, so it's important that we know this. Okay, so there are 4 P's in pain management, right? The first P is the patient, right? And what does the patient do to it? Basically, the anatomy, the age, weight, whether the patient has comorbidities or allergies. Now, when I was a postgraduate and there was one patient who constantly complained of pain despite giving him the best of blocks. Later on, when we did an OPG, I'm talking about 91, when we did an OPG and we found that the patient has got a bifid mandibular nerve. Okay, so this was the factor which didn't give him adequate anesthesia. Age of the patient, for a very young patient and a very old patient, you need to be very cautious with the amount of local anesthesia that you're giving. Same with the age, right? Comorbidities, a patient who's suffering from cardiovascular disease, such as patient has got an ischemic attack, or the patient may be a patient who's on long-term anticoagulant. In such cases, you need to be very careful. And I'm quite sure that you know what happens if the patient has got allergies. The second one is practitioner's technique. Now, this is something which we should keep doing. When we keep learning, we keep practicing. The more you work, the better hand you have. Sometimes your local anesthesia fails because you have not kept into mind the landmarks. Okay, you have forgotten the landmarks, or maybe if you're giving an inferior nerve block, you're too anterior. Or it goes posteriorly and enters into the parotid and causing the patient facial paralysis. Okay, so learn the optimal technique, right, which is suited. If you're working on the anterior teeth, I don't believe that you should give an inferior alveolar nerve block. You can do with much other thing. The third P is product. So what kind of product are we going to use? If we are going to use something like if you're going to use Articaine, that's good for an orthodontic extraction of the upper premolar or extraction of teeth in kids, because you can do with the infiltration only. The second thing is, what is the duration? Articaine gives you a longer duration. You supplement it with bupivacaine, so that gives you very prolonged. So that is the product part of it. Okay, and certain products have different indications, such as mepivacaine, though it is not available in India. Maybe sometime we're going to see it. Mepivacaine can be given safely in patients who got cardiac conditions, right? And the fourth P is procedure. How much time are we going to spend with each procedure? Maybe you're doing a full mouth implant. So in such cases, it is extremely important that we select the anesthesia properly. Don't inject the upper and lower arches at the same time, because your local anesthesia is going to go waste if you wait for the lower to finish the upper arch and then you come to the lower arch. So inject it in such a way that you inject minimally. At the same time, you have got adequate anesthesia. You wait for the near completion of the maxillary arch and then you move to the mandibular arch, or vice versa, whatever you select it to be. So this is what the patient fears, right? You give local anesthesia and the patient is very happy, right? So that is what local anesthesia does to us. There are different indications: extraction of teeth, root canal. Since I come from OMFS, and in this corona period where it was difficult, to do a case under general anesthesia, I'm saying difficult, it was not impossible, because to get the OT, you have to wait for a long time to get the OT cleared. And also we did a lot of procedures. We did especially the mandibular fractures under local anesthesia. Most commonly is dental implants or draining of an abscess. And there could be many, many more uses. Even if you want to do a ceramic crown and you find that the you got very less clearance, so you can use local anesthesia, right, to minimize the pain. So the ideal properties of local anesthesia, this is something which is from the textbook, right? So those interested can obviously take the presentation from me, or I think it's on Facebook. Am I right, Anil? It's on Facebook. It's going live.
So we'll
Yeah.
put it on YouTube, sir.
YouTube. Okay, YouTube. Yeah.
Yes,
so
sir.
It is going to be there
on.
in your YouTube. Yeah, sure.
Yes.
Anytime.
Yes.
So you have, all these benefits, which are, which you should have all these benefits of local anesthesia. The best part is it is reversible. Okay. Even general anesthesia is reversible. But then local anesthesia, the patient comes, get the procedure done and goes back the same day, or maybe within a couple of hours, right? So that is the advantage, and these are the ideal properties of local anesthesia. It should be sterile or capable of being sterilized. The biggest problem, as I'll come to it, I'll deal with it later in my later slide. So the advantage of using cartridges is something which is, which can be best utilized here. When you use a cartridge, you have a sterile cartridge, right, which is pre-sterile, and you use only 1.8 ml, right? So that is the advantage. If you use a multi-dose vial, then obviously there's a risk of introducing microorganisms or any kind of contaminant in that. So which local anesthesia to opt for? Now this is based on, there are 2-3 things that we're going to talk about: the length of the procedure, the vasoconstrictor, etc. If it's an ultra short duration procedure, maybe something between 15 minutes to 45 minutes, then you can use lignocaine without vasoconstrictor. And of course, this also has the benefit that in patients who have got a problem of ischemic heart disease, then obviously you have to use local anesthesia without a vasoconstrictor adrenaline, because that's going to cause a lot of problems. Now, my advice here is that if you, you should always consult the patient's physician before you undertake it, physician or cardiologist. Don't go and say that Dr. Shenoi spoke on this on 19th of December, that you can use lignocaine without vasoconstrictor. In patients who have got a history of cardiac diseases, always consult the cardiologist or the intensivist or the physician, right? If it's a short duration procedure, you can add epinephrine to it, okay? That is 1:100,000. And in those patients who are moderately hypertensive, literature says that you can use local anesthesia with epinephrine for about, 4 ml of solution, right? That can be safely used. Don't go beyond that. Make sure that you have mastered the technique and you give in the right place, the target area, so that you don't have to repeat the pricks, right? If something happens, like, if you give local anesthesia without adrenaline, what is going to happen is, because of the pain, there is going to be release of endogenous catecholamines, and that can cause a greater damage to the patient than the exogenous epinephrine which is there. Intermediate duration, let us say between 45 minutes to 1 hour and a half and 2 hours, articaine is good. It's a pretty safe local anesthesia. And long duration, you can give bupivacaine. Etidocaine is not available in India, as I know of, right? Bupivacaine is available. The only thing is bupivacaine is a vasodilating agent. So you will have a problem with that. So better to supplement it with adrenaline if it is not available in that, and then you can carry out your procedure, or you can give it as a, as an adjunct analgesic, which I'll talk about later. Okay. The second is need for hemostasis. Okay. So you add vasoconstrictor. Now this counteracts the vasodilation. Now most of the local anesthetic agents, except cocaine. Now cocaine, we don't get it in India, right? Now these agents are vasodilators. So what happens is, when you inject, there's going to be a lot of bleeding. So if you add vasoconstrictor, there's going to be reduced bleeding. It's going to stay there for a longer time and obviously reduce the risk of toxicity. Okay. So when you add the vasoconstrictor, it's going to have that benefit. The second thing is the duration of the desired effect, the physical condition of the patient. Now I said moderately hypertensive patient, yes, you can go ahead and use epinephrine for about, concentration of 1:1 lakh to 1:2 lakhs. Okay. The desire to achieve, but having kept in mind that, the patient does not have a cardiac condition. those patients who've undergone wall replacement surgeries, in such patients, you can, with the help of with the consultation of the physician or the anesthetist, you can safely go ahead and use epinephrine also, but then that depends from the treating physician, okay, and concurrent medications. So whether the patient is having some kind of a blood thinner or an anticoagulant, so that is very important. Now, like I said, congenital heart disease, vasoconstrictors to be kept to a minimum. Rheumatic heart disease, minimal vasoconstrictor. Coronary heart disease or ischemic heart disease, vasoconstrictors are contraindicated. In congestive heart failure, minimal, or you can omit it. In diabetes mellitus, because it increases the blood sugar level, you can omit it if you can. In thyroid patients, in hyperthyroid patients, kindly avoid using vasoconstrictors because it leads to something called as a thyroid storm, and the patient is severely compromised. Okay. So this leads to us thinking about a lot of molecules, and basically in India we are safe because we have a very limited spectrum. Now this is what I was talking about. These are molecules from Septodont. Okay, so this is lignocaine, this is mepivacaine. Mepivacaine, they had introduced it, but they had to stop it because of some regulatory issue, and they are working on it. I don't know when it is going to happen. And this is articaine, Septanest. Okay, now Septanest is available only in the form of cartridges. We have the luxury of using a vial. Okay, in a, if you're working in a institutional setup like a dental college or somewhere, you have to use a vial, but make sure that you don't stick the needle inside the vial and keep it there, because there can be bacterial ingress and that can cause a lot of problems. Number one. Number two, if in this COVID period, different people will be handling that same vial, so it is better to avoid it and use a cartridge. Okay, earlier the cartridges were slightly difficult because aspiration was an issue. Now you got self-aspirating needles which you can use, and that will be beneficial for the patient, right? You can have, you are having aspirating cartridge holders where you can aspirate and then inject. Okay. The workhorse is lidocaine, which is an amide. It is more vasodilating than mepivacaine, and this is a little problem with that because it is slightly acidic, right? So we need to bring it to a more basic level, which I'll be dealing shortly, right? Anesthetic half-life is 90 minutes. So in a short duration procedure, this is good. We call it a workhorse because you can use it in so many situations. It is no doubt it has got a not such a long duration of action as compared to articaine, because articaine came to use much later, but we have been using it day in and day out without even realizing that it's a savior, and it's a pretty safe drug as compared to procaine. Okay, the advantages of amide is it's an extremely rare incidence of allergy, and whatever allergic reaction you see, right, that is basically because of the uh, uh, the preservative which is there, which is either chlorbutyl or any other which is there. So
Sir, unmute, sir. Hello. Shenoi, sir, please.
yeah, okay.
Yeah.
I don't know how it happened. Maybe somebody muted me.
Yes. Yes.
So do you want me to go to the previous slide, or this is okay? Articaine. I was talking about articaine.
Yes, sir.
Yeah. So the advantage of articaine is that it's very safe, right? And the the thiophene ring which is there, this leads to greater lipid solubility. So when you mean by greater lipid solubility, it tends to permeate or perfuse better into the tissues, and that is the reason why in maxillary teeth one can avoid giving the palatal infiltration which is there. Okay. Now, this palatal infiltration is basically used by us maxillofacial surgeons because you have to retract the palatal gingiva. And that is one of the most painful injections that you know of. So what happens is that you can we have done studies where we have extracted orthodontic teeth, we've done orthodontic extractions, and the result was very good. Okay. So there are studies which I was talking about, using Articaine, and Articaine is pretty safe. There are various studies, I'll come to it again. This is how it happens. Part of it is in the liver and most of it is in the bloodstream. So there is less amount of, problems that you can see. And in those patients who got a hepatic problem or a liver disease, you can safely give Articaine, which may be a problem with lidocaine. Okay. So this is what I was talking about. 95% is degraded in the blood and 5% in the liver. So Articaine is pretty safe that way. Okay. So this is another study which has been shown, and Articaine was definitely effective than lignocaine in providing anesthetic success in the first molar region for routine dental procedures. The the adverse reactions may be more or less the same, right? And the depth of anesthesia with Articaine is much more as compared to lignocaine. So what are the benefits of Articaine versus lignocaine? Now, why am I stressing on Articaine is basically because of the safety profile and the ease of administering the local anesthesia which can be done. Okay, so you have a faster onset. It's a more potent drug. The duration is longer and got a fantastic safety profile. In addition, you do not have problems of contamination or infected local anesthesia because you are going to use only the cartridges. Okay. Now, what I'm going to show here is, Anil, there are two videos. I think for the paucity of time, I may have to skip one, but I'll show the mandibular technique, right?
Okay.
Now, as Anil said earlier, so this is basically, you got to keep in mind. So the deepest point is the coronoid notch on the anterior border. So the needle which you're going to see here is slightly different. It's got a needle with a safety sheath, right? Now, what you have seen here is that this gentleman is saying that, you identify the pterygomandibular raphe, but no patient comes with pterygomandibular raphe written over here. So you have to be very cautious. You have to be very careful. You have to learn the landmarks time and again so that you can administer the, yeah. So keep in mind, it is extremely important that you strike the bone, okay? And after ensuring that you're in the proper direction. Sometimes the most common mistake is that we are too anterior to it actually. So obviously the anesthesia is not going to take effect. So having kept in mind the bisecting technique, bisecting the nail, right? So you go inside and strike the bone. If you don't strike the bone, now there's a second scenario. If you don't strike the bone, then what is going to happen is that you're going to enter the substance of the parotid, which is encircling the mandible on the posterior side. So when you inject it in the substance of the parotid, it's going to diffuse through the parotid, and ultimately the patient has got, the patient's facial muscles droop on that particular side. So make sure that you strike the bone, withdraw the needle, and then deposit. Oh, sorry. I think it was somewhere over here. Yeah. Okay, now this is a pretty long video, so I might just skip it. There are a lot of videos which are available on the net, right? You can always see them and learn a lot from them. And you got the best of teachers in your college, right? So I'm sure that they're going to do a great job. What we do is, like Anil has rightly said, we conduct workshops. And unfortunately, for the last 10 months, I have not moved out of Nagpur. But we have a model which we developed, and we've done many of these, from all parts of the country we've done. So we do this so that the students gain confidence. There are studies also which have proved that they are good. This is something which we should make us feel. Hello. Yeah. So this is something which we Indians should be proud of, because Vazirani is not an Italian, but he is an Indian, Sundar Vazirani, who devised this technique. And this technique is going to, it is helpful in those patients who are slightly, worried or apprehensive kind of patients, and who got a limited mouth opening. So this is the Vazirani echinosis technique. We are keeping the barrel of the syringe parallel to the maxillary gingiva, and when you insert the needle in the pterygomandibular area, you are directly over the mandibular foramen. And when you deposit it, the patient gets good relief from pain. The only thing is that the drawback of this is that you cannot use it for, solely for extraction of teeth, the molar teeth, because it kind of does not provide full anesthesia to the core fibers. I'll come to it in a little while, right? So this is good if you want to carry out a short procedure, nothing much invasive like an extraction, or maybe extraction of mobile teeth is also good with this. This is the Gauget's technique. Now, Gauget's was an Australian dentist, not a Max Pack. He was a dentist who devised this technique. The problem with the conventional local anesthesia techniques of inferior alveolar nerve have got a success rate somewhere between 65 to 80%. So that means 20 to 35% of the times you miss it. And that is because of the anatomy. Now, when you master this technique, which is going to be a study for us, when you master this technique, it's got a steep learning curve. But once you master it, you're going to do very well, because this has got more than a 95% rate of success. So that is the advantage of using Gauget's technique, where you are injecting it nearly close to the mandibular condyle, and this is something that kind of put the fear of us. Even I am not very confident of using it because it is slightly demanding, and we worry about this internal maxillary artery which is closed down, right? So you have to be very cautious when you use it. Right? Now we have talked all about the various techniques. We should talk a little bit about failures also. So the failure can happen at any step, right? And it can happen right from the time of selection of the local anesthetic model or the molecule, or it can be the armamentarium which you use. So the solution, if it is outdated or contaminated, obviously it is going to cause a problem. And that is why this practice of keeping the needle inserted is a little bit dicey, because when you want to draw the local anesthesia again, there's a chance that you may accidentally introduce microorganisms into it, despite the fact that it has got a preservative. Okay. The second wrong technique, what can happen is that if you're not allowing insufficient time for it to diffuse, the wrong anatomical position and the insufficient solution. Now, I remember when I was a PG student, and there was this patient whom we had to do a symphyseal fracture under local anesthesia, and no amount of injecting the local anesthesia had effect. To the extent that, first we thought that the anesthesia is local anesthetic solution is outdated. The second thing that came to our mind is that, whether the patient is, refractory to local anesthesia, and that is what happened. Now, unfortunately, at that time, somewhere in 91, we didn't have the means of checking it out. And second thing is that, he was a prisoner who had a fracture of the mandible. So we could not have the luxury of time to investigate a lot. But now, actually, if I look back at it, maybe the patient was, there are patients who are resistant to local anesthesia. Maybe we could have used a different local anesthetic at that time, right? Insufficient solution, right? So that is a big cause. Having said that, usually 1.8 ml is good enough for extraction of teeth, right? Injecting into an inflamed tissue. So this is acidic, your local anesthetic solution is acidic, and obviously your local anesthesia is not going to work. So how do we overcome it? I'll be just dealing it in some subsequent slides, right? So to sum up the failures, right, there are, it could be basically because of a wrong technique. We have not paid heed to the various landmarks which are there. The patient has pain because we have used improper technique. The core fibers have not got anesthetized, only the mantle fibers have got anesthetized, right? Inadequate volume, presence of infection, operator inexperience. Now, this is something which we should keep practicing. We should keep learning. You should make it a point, to insist with your professor or your teacher that I want to learn new things. Please tell me, and they would be so happy to help you, right? You've got a wonderful set of teachers. I mean, wherever we are, and of course, nursing by Patel Dental College has got the best teachers, and psychological issues. Now, this is something which you can't overcome in a routine basis. I have patients in whom I have to use general anesthesia because these patients are not willing for local anesthesia. Okay, there's nothing wrong with it. So now, this is something that I just talked about the low pH when you're dealing with an acidic area. So what happens is that there's more pain on injection, there's failure of local anesthesia. So what we do is we call this as buffering. When you add soda bicarb, you call it as buffering. Now the question comes that why don't we have a buffered local anesthesia as a commercial preparation? The problem is that a buffered local anesthesia, if it is there, it is going to precipitate and it is going to be ineffective. The success of using buffered anesthesia is basically when you use it fresh, and therein lies the problem. That is why it has not gained much popularity. Okay. So what happens is that when you add 0.3 ml of soda bicarb, okay, which is available commercially, okay, and you add it to 2 ml of solution, it makes it as a 7.5% soda bicarb solution. Now, this is the most optimal form of solution that is there. The advantage is that the pain is less, the pain on injection is less, the duration is more, right? And the patient tolerates it very well. So why can't we use it routinely? It is not possible to make it as a buffered solution. Okay. In a clinic, I'm very sorry to say actually. So then, I mean, one can do it, but in a clinic where you have got patients waiting outside, you can't try all these things in a clinic. It is good if you're working in an institution, right? So this is another study with bupivacaine, okay, buffered local anesthesia and bupivacaine. So basically, when you make it as a buffered solution, you overcome the problems of injecting in an area which has got infection. Okay? So in such cases, the chances that your block which you're going to administer is going to be very successful. Now, what the other chance of reducing the failure is by increasing the spread of solution by using higher uronidase, okay, hylase. So this has got more spread, okay, and the patient is more comfortable, right? So it's an enzyme that breaks the intercellular cement. You know, hyaluronidase is basically used in a lot of clinical situations, from ischemic heart disease to so on and so forth, to break the barriers, the tissue barriers. So that is the advantage of using hyaluronidase. What are the complications that are there? Okay, so they can be either local or they can be systemic. We'll deal with the local ones. Now there have been, we have presented or we have published a lot of articles in the FAMDEN journal. Okay, and this is one of my students who done one of them, and another has presented the second part of the series. Okay, so local complications can be a hematoma, or you have a broken needle, right? Hematoma has come here, I don't know. What I wanted to show is that there's a broken needle over here, and this broken needle, if you see the tip, which is reasonably long, you can attempt to remove it. But if you don't see it and you just are guessing that it is there, then you're going to land up in a lot of problems. You could push it further. It can go into the infratemporal space, and that's going to be a big mess for you to remove. It could damage a vessel. So in such cases, you take an X-ray, you take X-rays in mutually perpendicular directions. So if you've taken an OPG, please complement it by using a PA mandible, right? And then proceed to remove it. When does hematoma happen? I think I should have, yeah. I think that particular thing came earlier. A hematoma happens when we yes, thank you. Hematoma happens usually when we inject in the pterygomandibular, in the pterygopalatal region for a PSA nerve block. And unfortunately, if your needle is not directed posteriorly, medially, and superiorly, you could end up damaging the pterygoid plexus. Now, what happens is that it immediately balloons up. The thing is that you can always overcome it. Can I request the participants to stay muted, please? Yeah, thank you. So it would tend to balloon up. Now, this is slightly scary, okay, for the patient and for the first time, a dentist who's injecting it. There's nothing to worry about it. Immediately put a pressure pack. What I do is, it has happened to me, and the patient was a compromised patient in the sense that the patient was on aspirin and it could have been catastrophic. But we can't be sure about where the needle is going, despite the fact that we use the best of technique. It can happen. It does happen. Complications do happen with the best of people. So what you do is you put a pressure pack inside, you put a gauze pack inside, and you put a pressure pack outside. Use a reusable ice pack or a cold pack, or just simple ice cubes in a plastic bag, and tell the patient to keep it firmly from outside, right? If it is an ice pack, then it's better to remove it intermittently. Otherwise, there's going to be necrosis. What is more disturbing to the patient is, or discomforting the patient is the ultimately when it gets resolved, the RBCs have got hemolyzed here, and that causes blackening. Now this blackened skin is going to go away in a little bit of time. It might take about 14 to 20 days for it to resolve, right? When they get absorbed into the bloodstream. So till such time, that you please counsel the patient and tell it's nothing very serious. Otherwise, the patient is going to eat your head that you're not told me that this is going to happen. Now, these are some complications that happen. Facial nerve paralysis, trismus, soft tissue injury, pain on injection, burning on injection. Now, these two things, pain on injection and burning on injection, could be because of a dated solution. Facial nerve paralysis happens when you are injecting into the parotid, right? It does happen. It has happened in my unit. Nothing to worry about. And you just need to counsel the patient. Now, for those who are in the third year or whatever, the affected part is the left side, because in the right side the patient is able to close, in the left side the patient is not able to close. So obviously the doctor injected in the left parotid, right? Trismus happens if you're kind of damaging the medial pterygoid muscle. So you have to use a very sharp needle, and your technique should be perfect. Can numbness be reversed? Yes, it can be reversed. This is going to be very helpful for the young patient, the pediatric patient group, because they might bite their lip, and what is available is phentolamine mesylate, right, or Oraverse. This will it will counteract the action of local anesthesia, and this will give a good result. Okay, so the patient is safe. As I come to the end of it, just a short note about systemic complications. This was again an article which we had done, right? Systemic complications of anesthesia, local anesthesia, which is available in the Famden Journal. I'm not going to talk in detail because this itself is a lecture on its own. So syncope is, I'm sure that there are going to be many ladies in this webinar. So basically, if you have seen syncope happening, it happens to males. And why does that happen? That happens because, the basic reaction to something that we feel worried about, right, which we fear, is flight or fright. Okay, flight means to run away. Now, obviously, if somebody who claims to do a lot of bodybuilding, a 25-year-old is sitting on the dental chair, and suddenly you hold the needle in front of him like this, especially the Bollywood style. If you hold it like this, so the patient is going to worry, right? The patient will try to run. So that is the physiologic reaction. And to help him run, there's pooling of blood in the periphery. There's pooling of blood in the periphery. The cerebral blood flow is reduced, and that is why the patient faints. So usually you see it is the young males who faint, right? So there are psychogenic factors such as fright, anxiety, emotional stress, unwelcome news, and the sight of blood, surgical procedure, instruments, etc. So many patients, so many mothers faint when they take their children to the pedodontist. Okay. And there are non-psychogenic factors such as standing erect or in a standing posture, hunger from dieting, exhaustion, poor physical condition, hot, humid, crowded environment. Now, what we feel as crowded environment, sometimes it's a boon and sometimes it's a bane. When we are in a discotheque, right, and you are enjoying, it doesn't matter, in a small room that can accommodate 50 people has got 100 people in it. But we get angry when we are going in a bus or in a local train, and we find, अरे आज कितना भरा हुआ है, कैसा जाएंगे. So these are all things, which we kind of adapted to ourselves. Okay. So I told you about the male gender, right? Age, again, I told you, young males. Okay. So this is the basic, in short, basic about syncope. This is one of the most common situations that we come across. Please do not give the patient glucose. Glucose is not, or dextrose or whatever, is not the solution to syncope. Try to manage it non-pharmacologically. So what you do is you raise the feet, right? Tell the patient to move the limbs. If the patient has got severe bradycardia, then you inject atropine 0.6 milligrams, right? And then obviously ensure that the patient has recovered fully. Okay. If the patient has fainted, don't continue with your dental treatment. अरे वाह, अब तो बहुत अच्छा cooperation मिल रहा है. Don't try that, because that is against the ethics. Okay. So what you need to do is make the patient at one level. The trunk, the head, and the limbs are in one level, so that there is adequate, blood that flows between these three parts. Never try to reduce, try to tilt the head low down, because that will increase the cerebral blood pressure, which is not good. Okay. So in short, the algorithm would be discontinue the procedure, activate the emergency team, position, right? The patient should be supine, right? And then assess the vitals of the patient and give definitive management. Oxygen and atropine bradycardia pulses. The second thing that we're going to talk about is toxicity, right? So in toxicity, Anil, just 3 or 4 minutes more. Is that okay?
Yes, sir.
So in I'm nearly done now. This is one of the last parts. Okay. So in toxicity, what happens is that if we don't take into account of how much local anesthesia we're giving, that is the reason why in your third year, you are asked the question time and again, कि हम कितना दे सकते हैं? What is the amount of local anesthesia that you can safely inject? So it's very important to know, because if you're dealing with a small frail patient, obviously you could end up with a toxicity with even less amount of dose, or if you directly inject into the vessel. Allergy is something, though usually with articaine and lidocaine it doesn't happen. Syncope we talked about, and hyperventilation is also the same. It's a manifestation of fear, right? Now, what happens with systemic toxicity is that, with the increasing amount of local anesthesia, which you see here, right? There could be, with the central nervous system, there could be respiratory arrest and death. And with the cardiovascular system, there could be myocardial ischemia, hypotension, and ultimately cardiac arrest. So one has to be very careful about how much of local anesthesia you can give. Now, the rule of the thumb is that, with adrenaline, you can give somewhere close to 7 milligram per kg body weight. And without adrenaline is 4.4. Now, that doesn't mean that if the patient is 100 kilos, you can administer 700 milligrams. It can't exceed more than 500 milligrams. And why should it go even to that? If your technique is perfect, you're not going to, you can just use, 2 ml of solution per quadrant if you're good enough. So, position of the patient, airway, breathing, circulation, and definitive. In definitive, if you see that the patient is having toxicity, which appear like seizures, ensure that you summon the the physician, and in the meantime you administer the patient a drug like a benzodiazepine, so that the patient's CNS gets calmed. Okay. From painful to painless, you got new vistas. Okay. Which we have talked about. So this entire series, I think 6 articles were published last year in the Famden Journal. Please go through it. It's going to be very helpful for you. So we have got vibrotactile devices. Now this distracts the patient and the patient is pretty comfortable. This is a study which has been done by my student. This is a computer controlled local anesthesia delivery system. If you are, you've got a good practice, why not invest in something like this? So this will deliver only the optimal amount of local anesthesia that is needed. So the risk of toxicity or untoward incidents is reduced. So this is basically, there are studies which have been done and prove that wand is very good. The only thing is it is expensive. So this is another system. It is pre-programmed. You can deliver local anesthesia very gently. Then you got jet injectors. Jet injectors can't be used technically for the inferior alveolar nerve, but you can use it for infiltration. So it's a pressurized local anesthesia which is given, and that is beneficial for the patients who are young. Okay. So these are the different needle-free injection techniques. Okay, on the basis of working on the mechanism of drug delivery, on the type of load, and on the basis of site of delivery, right? So you can use different types. These are again, which are available. I'm sure once they upload it into the YouTube, you can see it aram se. This is for endodontic practice. This is called as intraosseous injection, X-tip or Stebident system, where you give a preparatory local anesthesia. Then what you do is there's a special delivery system which you use, and that gives it just below the roots of the teeth. So one, you are avoiding excess anesthesia. Number two, this is good for endodontic practice only, okay, not for extraction of teeth. So you are sure that your pulpal anesthesia is going to work. So basic technique would be a sharp sterile needle, positioning of the patient, use topical anesthesia, keep communicating with the patient, keep talking to the patient, and then taut the tissues. What do you mean by taut? When you stretch the tissue, the needle goes in easier, okay, and causing less pain. At the same time, you are able to visualize also properly. So this is tauting, right? Use of insert the needle, inject a few drops, advance the needle and aspirate, and slow deposition of solution, 1 ml per minute, okay, by the clock. Okay, मैं 1 मिनट ऐसा वाला हिसाब नहीं है. This is the specialty wise anesthesia. For endo, you got different techniques. For oral surgery, you got regional block and infiltration for maxilla. And for pediatric dentistry, which is a concern, you can use Articane. So the take-home message as I complete my talk is proper armamentarium, selection of the appropriate molecule, bear in mind the anatomical landmarks and the right injection techniques and supplemental anesthetic measures. I would like to thank Dr.Anil Managutti, Dean Dr. Patel sir, Anil and his team, the management of Narsinbhai Patel Dental College, Visnagar, and I hope that it's going to be something beneficial. I would also like to acknowledge the efforts of Dr. Shruti Jain and Dr. Jignesh, who helped me with this particular the module which you got and the PPT. Thank you so much.
Thank you, sir. Thank you for a wonderful presentation.
Thank you.
Questions are there, sir. Ruchit. Hello.
The patient, because I have certain patients and they are VIPs. So these patients would not agree to local anesthesia at all. Well, if the patient is scared of local anesthesia, then you give the option of general anesthesia or sedation, right? But what I would like to say here is that please don't use sedation yourself. Have an anesthetist with you, because in India we do not have the the training to give sedation.
Okay.
I mean, you can get trained, but you are not authorized to use it. So it's always better to have, yeah.
And there are no set words to tell to the patient. It depends on the patient to patient. And
Yes.
So
the next question, Rushit, what yes, you can do is maybe as a part of this webinar series, you can have somebody talk on practice management, because that is something which will help these patients. Yes.
Right suggestion.
Exactly. That's a very good suggestion, sir.
Yeah.
So the next set of questions, there are quite a few from Avinash. Yeah. The first question he is asking, what local anesthesia sensitivity reaction is seen on hand when test dose is given?
The first thing is, when you're doing a local anesthesia sensitivity, can the...
Please unmute yourself, everyone. Please.
I will mute. I will just check.
Mute yourself. I'm sorry. Mute yourself.
Yeah.
Yes, sir.
So if I can go ahead, what you...
Anil, you are muted, sir.
Yeah. No. Yeah, yes, I've got it. I've seen it. Yes. So when you are whenever you are wanting to do a skin test, right? Make sure that you're using local anesthesia without adrenaline, and you have every possible, the emergency kit with you. If something happens, then you should be able to counteract it. Now, what you see usually, if you see on the ventral aspect of the, the forearm, right? When you inject, it should be a subdermal dose or a subcutaneous dose, right? You mark that area, put the time with a ball pen, okay? And you notice if there's any kind of, a swelling or a wheal which happens, or if the patient is getting distressed, the patient can get distressed with a small amount also. So consent is very important before you embark on any treatment, right? You explain the patient that this is going to happen, especially to those who have not been exposed to local anesthesia, right?
So the
I
next
think
question.
Divya also asked the same question. I saw it on the chat box. It's the same thing.
Right.
There is a question from Avinash in the same set of questions. What is the alternative for lignocaine if sensitivity is seen, and how to manage if sensitivity is seen?
Yeah, if sensitivity is seen, basically, like usually what happens is it's not, kind of related with the lignocaine. I have not seen. It's been more than 25, let's say 30 final BDS in 1990. Yeah. So in the 30 years of practice, I have not seen an allergic reaction happening to lignocaine. Not that does not exclude me from having it or anybody having it. Right? There's a lot of disturbance that is happening. I don't know.
Yeah, somebody.
It happens. Don't worry, and that's a perfectly normal thing which happens. So people forget to mute themselves.
Okay. Sir, next question is from Dr. Urvashi. Can you please explain the Kurtzhomer technique or a Kantrovic technique? And if not possible to explain, can you please let us know in which book it is mentioned?
Which one?
Kurtzhomer technique.
I don't know.
Okay. Yes, sir. Next is, what is the scope of twin mix as inferior alveolar nerve block in mandibular wisdom tooth disimpaction?
What is twin mix?
Twin mix, yes, sir.
I don't know what is meant by twin mix.
Okay.
If somebody knows, then Anil, I don't know. I don't know what. Maybe as I interpret it, it could be you start with lignocaine and you add bupivacaine at the end of it, so that the patient has got more. Other than that, I am not sure what this is actually.
Sure, sir. The next question is from Dr. Divya. Why glucose is contraindicated in syncope management? I think
if we are feeling hungry, would we take water? That's my answer.
Exactly, sir. That's the perfect way of putting it.
Yeah.
Okay. So next question is, if we inject local anesthesia after applying topical anesthesia, how can we be sure that the patient is anesthetized?
See, when you're applying a topical anesthetic, it's only the mucosa that is going to get anesthetized. So the pain on insertion of the needle is reduced when you use a topical anesthesia. If you don't have a topical anesthesia, what you can do is, you can just use the applicator. This is for the palate, right? And you can just press it so that the nerves get temporarily, it's something like a neuropraxia, and then you can administer.
Sure, sir. Sir, we have a comment in chat box that twin mix is a combination of lignocaine and Dexona.
Dexona or dexmedetomine? I don't know.
I also doubt.
Dexmedetomine is also there. Yeah.
Yes, sir. Yes, sir. I think there are few questions which are already given in the books. How much local anesthesia we inject in one time? I think it is already given in books, so we won't take them. I think all of them are given in books. How to aspirate in a cartridge anesthesia? I think we have a specialized systems to do aspirations.
You aspirate the same way. You just put the cartridge and you aspirate it. It's not anything different from using a plastic syringe.
Yes, sir.
Roshit, this is a way of the students taking revenge on us, if I may add, on a lighter vein. आप हमको क्वेश्चन पूछो, अभी मैं पूछता हूँ व्हाट इज ट्विन मिक्स.
सर आपकी एग्जाम चल रही है.
वही लग रहा है सर.
No problem, sir. We are keeping on them, and I think all
no,
of
but
them
it's good that many students have shown interest
yes.
asking questions.
That's wonderful.
And there are more than 300 participants are there.
Yes,
That
that's
was
very good, sir.
excellent. Excellent, sir. Excellent
Yes.
webinar. Good start.
Thank you so much.
So we'll take the last question and then we'll move forward for the vote of thanks. I think how to manage intraosseous technique, as it is very painful to drill the bone and inject solution.
No, sir, that is what I said. You use a preparatory local anesthesia. You inject over that part where you're going to give the, insert the that tip, X tip, right? So
Yes,
if you
sir.
give a preparatory anesthesia, it's going to be,
Yes.
it's going to get reduced. And that is
Definitely.
basically for endo. You don't use it for exodontia. Okay.
Sure, sir. Sure, sir. I think because of the scarcity of time, we'll conclude this. And thank you so much, sir, for your presentation. I request Dr. Nirav to please proceed for the vote of thanks.
This was something which I also enjoyed, because looking at the interactive way it was, and hats off to you people for getting so many people on the
Yes.
webinar and so many people asking also. So, that
Yes,
pleases the person who's doing it. So thank you so much.
I
Thank
think
you, sir.
we
Thank
can
you, sir.
collect any more query. We can collect it and later on we can send it to sir
Sure,
for
sir.
any clarification, and it will be better.
Yeah.
Further interaction also will be there.
Yes, yes.
Yes. Next week we have a webinar on complications of LA also,
Yeah.
sir. In detail, so how to manage clinically. So few questions that we can answer in that also.
Yeah, sure,
Yes,
sure.
That is okay.
Yeah.
Thank you so much. Thank
Yes.
you.
Thank you, sir.
Thank you.
I enjoyed.
Thank you, all of you. Hi, I am Dr. Nirav Patel. With this, we come a successful come to an end of our first lecture of this webinar series. On behalf of the Department of Oral and Maxillofacial Surgery, Narsibhai Patel Dental College, Sakarchand Patel University, Gujarat, I feel honored to be extending this vote of thanks. Firstly, I take this opportunity to take a thanks Shri Prakashbhai Patel sir, President Sakarchand Patel University, for providing us such an excellent infrastructure and opportunity to conduct such unique webinars. I would also like to thank Dr. V.K. Srivastava sir, Provost, SPU, for his keen interest and the boosting energy for the entire show. Our ever enthusiastic and always smiling Dean sir needed a special mentioning for his motivational and the wholehearted support. We thank you, sir, for being our constant guiding path. I thank you, our speaker, Dr. Ramkrishna Shenoi, sir, for wonderful scientific deliberation and the sparing time for his busy schedule. I must say, this has set the perfect tone for a wonderful webinar series ahead. I thank you, our HOD, Dr. Anil Managutti, Dr. Shailesh Menon, Dr. Rushit Patel, Dr. Shivani, Dr. Disha, for the background works. They are the pillars of the strong foundation. I also thank all the participants for the participating in a huge number and sparing their valuable time to make this a grand beginning. Last but not the least, I thank my postgraduate students and the non-teaching staff of the Department of the wholehearted involvement. Once again, thank you all. Jai Hind. Thank you so much, Rama
Thank you.
sir.
Thank you. Thank you, Nirav. Thank you. Always a pleasure.
Thank you, sir.
Okay. Patel sir, hope to see you soon.
Yeah, thank you, sir. And I may come to Nagpur because they have decided in future one program they will have, and they will invite me. So
Yes, sir, yes.
there is a scope of meeting you again there in Nagpur. We'll meet there.
Definitely,
sir.
sir. Definitely.
Convey my
Okay.
regards to Madam
I
and
will.
all others.
Yes, sir. Okay. Thank you so much.
Thank you
Good
once
day.
again. Thank you once again, sir, for wonderful webinar. Thank you.
Sir.